بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. الحمد لله رب العالمين. يسعدني ويشرفني إن شاء الله في النهارده في الويبينار إن أنا أرحب بالأستاذ الدكتور محمد أحمد، أستاذ التخدير بجامعة الإسكندرية، وأستاذ التخدير في واستشاري التخدير في كينج فهد بالمملكة العربية السعودية. والحقيقة يعني أنا شهادتي في الأستاذ الدكتور محمد أحمد مجروحة، لأن هو أستاذ نبيل وبار وتقي ونقي وما شاء الله عليه معطاء، وما فيش مرة قصدته إن هو يقول لنا محاضرة إلا لما بيكون مرحب جدا جدا. فهو مرحب به ومرحب بكل أنواع العطاء. فأهلا وسهلا بأستاذ الدكتور محمد أحمد. برضو بيشرفني النهارده ان المودريتور بتاع الجلسه النهارده الاستاذ الدكتور محمد سالم، والحقيقه من اساتذتنا الافاضل في جامعه المنوفيه، ويتميز بالصدق ولين الخلق والتواضع الجم الحقيقه، وهو استاذنا الفاضل ويعني من منشئي الكارديو ثوراسيك انستيزيا في جامعه المنوفيه. وربنا يبارك في صحه استاذ الدكتور محمد احمد واستاذ الدكتور محمد سالم، ومنورين الدنيا كلها. وان شاء الله ان شاء الله يعني اكسبشنال ويبينار، وان شاء الله كل حاجه تعدي يعني بالعلم النافع علينا كلنا من اصغر حد لاكبر حد، وربنا ينفعنا كلنا. وان شاء الله ان شاء الله يكون هذا الوقت يعني مقدر في صحائف اعمالنا من الحسنات باذن الله، باذن الله سبحانه وتعالى، ويتقبلوا مننا خالصا لوجه الكريم. اهلا وسهلا دكتور محمد سالم، اتفضل يا فندم. حضرتك ميوت يا دكتور محمد.
السلام عليكم. تحياتي للدكتورة صفاء والمجهود الكبير ورعايتها للويبينار، وتحياتي للدكتور محمد وبالتوفيق. We are waiting for his presentation, listening for him. اتفضل دكتور محمد، سعداء بحضرتك.
بسم الله الرحمن الرحيم. شكرا جزيلا دكتورة صفاء على المقدمة اللي احنا اكيد ما نستحقهاش دهيت، وشكرا دكتور محمد سالم. Today we will gonna talk about cardiac anesthesia outside the OR. The title may be a little bit strange because how we will give cardiac anesthesia outside the operating room, but I mean cardiac anesthesia in the electrophysiology lab, specifically for arrhythmia ablation. The objectives of this talk, in the beginning, we will talk briefly about the mechanisms of arrhythmia, and then we will talk about the ablation procedures, the techniques, and the indications and the risks associated with these procedures. And then we will talk about how to give anesthesia for such risky patient outside the OR, away from the operating room in the electrophysiology lab, how this location is challenging for the anesthesiologist, then how we can prepare these patients, how we will monitor these patients, the management of anticoagulation during the procedure, and the anesthetic plan and strategy during this procedure. I apologize because the talk may be a little bit long. I will do my best to make it palatable. First of all, if we will talk about the ablation and arrhythmias and the electrophysiology, we have to start with the action potential of the cardiac muscles. We all remember that the action potential of the cardiac muscle has 5 phases: phase 0, 1, 2, 3, and 4. The resting transmembrane potential of the cardiac muscles is negative minus, it is minus 90 millivolts. Why it is minus? Because the sum of the ion charges inside the myocyte is negative. The negatively charged ions is more than the positively charged ions. And also outside, it is more positive compared to the inside of the myocytes. When the action potential starts, it starts with rapid influx of sodium ions inside the myocytes. Sodium ions, as we all know, are positively charged, and the rapid influx of these sodium ions will cause the negativity inside the myocytes to decrease. There is an increase of positive ions inside the myocytes. This will lead to change of the action of the transmembrane potential from minus 90 millivolt. It will go up, it will reach 0, and then it will be on the positive side. It will be more than 0, so it will turn into positive. So that's the sum of the ions inside the myocytes are towards the positivity. This is base 0 of the action potential. And then the sodium channels will close because it is time limited. It will close and potassium will start to go outside the myocytes. Potassium, as we know, is positively charged ions. This will decrease the positivity inside the myocytes. And then after a while, the calcium ions will go inside. There will be potassium ions going outside the myocytes and calcium ions going inside the myocytes. The net result is a steady state of there is no change of the transmembrane potential at this phase, which is phase 2, and there will be a plateau in the action potential. Then the calcium channels will be closed and potassium will continue to go outside the myocytes. This will decrease the positivity inside the myocytes until it reaches to the resting membrane potential, which is minus 90 millivolt. These phases are very important in understanding the mechanisms of arrhythmia that we will speak later about. We have 2 different types of cells inside the heart. We have the pacemaker cells present in the SA node, in the AV node, in the AV bundle, in the bundle branches, and in the Purkinje fibers. And we have the remaining myocytes in the cardiac wall. The pacemaker cells are different than the remaining myocytes because the pacemaker cells are peculiar. It has a criteria or phenomena which is automaticity. By automaticity, these pacemaker cells can initiate action potential spontaneously without any external stimulation. So these cells, it can start the action potential spontaneously. SA node cells, it starts the action potential spontaneously at a rate of 60 to 100 per minute. AV node, the rate is less than this. So these cells in the SA node, AV node, and the bundle branches, Purkinje fibers has this criteria, which is not available, which is not found in the remaining myocytes. The leading of the action potential, the starting point of the action potential in the normal heart is the SA node. It is the leading pacemaker of the whole heart. Also, the pacemaker cells, the resting membrane potential is less than minus 90 as the remaining myocytes. It is only minus 60. This makes these cells easy to be depolarized. So once it reaches from minus 60 to minus 40, the action potential will continue and it will spread from the pacemaker cells to surrounding myocytes. According to these phases, during phase 1 and 2 of the action potential, if the myocytes will be stimulated during these 2 phases, it will be completely refractory to any external stimulation. So any adjacent action potential coming to the myocytes while it is in phase 1 and 2, this action potential will be stopped, and the myocyte will be completely refractory, and the action potential will stop here. It will not spread to the adjacent cardiac tissue. During phase 3, which is a phase of repolarization, the myocytes will become relatively responsive. So it needs a strong action potential to respond to it. So the myocytes, if it will receive a strong action potential during this phase, it can respond, it will be triggered, and it can respond to the external action potential coming from the adjacent areas. In phase 4, this is the normal phase that during which the myocyte will respond to any action potential coming to it, arrive to it from the adjacent cardiac tissue. The sequence of depolarization in the normal heart, it starts from the SCA node, and then it will spread to the atrial tissue, to the right and left atrium, and from this atrium, it will reach the AV node, and then through the AV node, it will descend to the AV bundle and bundle branches and Purkinje fibers, and depolarization wave will spread to the whole heart. In the AV node, there will be delay in conduction, some delay in conduction of the action potential. This delay will allow the atrial contraction to empty the blood in the both atrium into the ventricle. And also it decreases the ventricular response if the action potential of the SCA node is charging in a high rate. It controls the rate that will reach to the ventricle. So it will not affect it keeps the cardiac output as normal as possible. The only way that transmit electrical activity from the atrium to the ventricle in normal heart is through the AV node and AV bundle and bundle branches. The atrium, both atria are in complete insulation electrically from both ventricles. There is a fibrous band which insulate the atria completely from the ventricle. So only through the AV node, AV bundle, bundle branches, this is the only way that electrical stimulation can reach the ventricle from the atria. And this is very important in discussing the mechanisms of arrhythmia, as we will see. We have three main mechanisms to produce arrhythmia. The first is enhanced automaticity. Automaticity, as we said, it is the ability to initiate spontaneous action potential. It is only available in normal heart in the pacemaker cells. If the automaticity is enhanced, so the pacemaker will will initiate more and more action potentials per minute, and this will increase the heart rate, and there may be some tachyarrhythmias or tachycardia. We have two types of enhanced automaticity. If the enhanced automaticity is in the pacemaker cells, this is enhanced normal automaticity, like what happens during sympathetic stimulation and stress. But if the enhanced automaticity is outside the pacemaker cells, so this is abnormal, because normally the remaining myocytes have no automaticity. If it will acquire this automaticity, this is enhanced abnormal automaticity, and it can cause arrhythmia. This is the first mechanism of arrhythmia. The second mechanism of arrhythmia is the triggered activity. By triggered activity, we mean that the myocytes will be triggered by action potential, abnormal action potential during the relative refractory period that we discussed before, in stage 3 of the action potential of the myocytes. If any myocyte will be triggered by stimulation during this period, and this stimulation was strong enough to initiate action potential, the new action potential will be irregular and abnormal and will produce arrhythmia. This is the second mechanism for producing arrhythmia. Both these two mechanisms are not the common mechanisms that produce arrhythmia, but the most common mechanism that produce arrhythmia is the re-entry. What do we mean by re-entry? During re-entry, we mean that there is an abnormal accessory pathway that transmits the electrical activity from the atria to the ventricle. We said that we have only one pathway that transmits the electrical activity from atria to the ventricle, which passes by the AV node and AV bundle branches, and Purkinje fibers, because we said atria are completely insulated electrically from the ventricle. So if there is another accessory pathway that transmits electrical potential from the atria to the ventricle, this will produce what is called re-entry. The accessory pathway, the abnormal accessory pathway, may pass through the AV node. If the abnormal accessory pathway will pass through the AV node, this is the AV nodal re-entry tachycardia. In this case, there are two pathways, one which is normal pathway, the slow pathway that passes through the AV node, and fast pathway that passes also through the AV node. So the first pathway will go through the AV node, and it will stimulate the produce action potential in the AV bundle here. So by the time the slow pathway reaches here, it will find these myocytes here in the absolute refractory period. So it cannot pass through these myocytes. But at the same time, it will find this myocyte here ready to receive the new action potential. So the stimulation will pass in this circuit. It will pass through this circuit, and it will go through this circuit to produce the circus movement here. And every time the circle will be completed, there will be new stimulation for the atrial tissue and the AV node, and the new action potential will be generated, and this will cause tachyarrhythmia. This type of tachyarrhythmia is called the AV nodal re-entry tachyarrhythmia. In another type, the abnormal accessory pathway does not pass through the AV node. AV node, the normal action potential will pass through the AV node, and the abnormal accessory pathway, it will not pass through the AV node. It will go directly from the atria to the ventricle. There is a breakdown of the insulating fibrous tissue here. So cardiac impulse can go directly from the atria to the ventricle without any delay of the AV node. So it will be fast. This fast pathway will depolarize the ventricle. The slow pathway that will pass through the AV node, when it comes here, it will stop here because it will find the ventricle already in the absolute refractory period. By the time the fast pathway complete its circle, it can go through the AV bundle in a backward direction to the AV node, and it can stimulate the atrium again and produce another action potential, and will be cause of the tachyarrhythmia. This is the AV re-entry tachyarrhythmia. The bradyarrhythmia has two different mechanisms. The first is depressed automaticity, and the second is conduction block. But we will concentrate today on the tachyarrhythmia because tachyarrhythmia is our goal in ablation therapy. So what is catheter-based ablation techniques? The catheter-based ablation technique is a technique to treat mainly the drug-resistant arrhythmias. If the arrhythmias are not responding to antiarrhythmic medications. So the next step is to do ablation for these arrhythmias. By ablation, we mean we have to produce damage, transmural damage from the endocardium to the epicardium of the focus that initiates the arrhythmia. And it has to be, the damage has to be limited to the focus. It doesn't have to spread to the adjacent myocardial tissue. And also it doesn't have to spread to the adjacent and nearby organs, as we will see later on. Indications for ablation, as we said, medication-resistant arrhythmias. If there is a serious side effects from the antiarrhythmic medications, patient cannot tolerate the side effects of the antiarrhythmic medications. There are certain types of arrhythmias like Wolff-Parkinson-White syndrome and supraventricular tachycardia. These kinds of arrhythmia are well known to respond well to ablation therapy. And also if there is a high-risk complication from the arrhythmias like recurrent VTAC. So these are the indications for ablation therapy. Contraindications are mostly relative. The most common and most important contraindication is the presence of thrombi inside the heart. If there is any thrombus inside the heart, we will postpone the ablation until this thrombus is resolved, because ablation and catheterization of the heart while there is thrombus inside the cardiac chambers puts the patient at high risk to develop cerebrovascular stroke. Also, if there is coagulopathy, we have to correct this coagulopathy first. If the patient is pregnant, so we will postpone the ablation therapy until the patient delivers to avoid the hazard for radiation exposure. If there is a vascular access problem, femoral vein or femoral artery problem, inferior vena cava problem, in these cases, we have to postpone the ablation until we resolve these problems in the vascular access, although it can be done through the internal jugular vein instead of the femoral vein. The techniques of ablation therapy, it differ according to which type of energy that we will use to do the ablation. The most commonly energy type is the radiofrequency ablation. Radiofrequency ablation, we will use an ablation catheter that utilize the energy utilized here is the alternating electric current, exactly like the diathermy used during the surgery. So the radiofrequency catheter will use thermal energy to burn the site of the initiation of the arrhythmias. But this thermal energy that will burn the site of the focus of arrhythmia, the burning effect and the damage effect may extend to the surrounding tissue. So to limit the effect of the thermal energy on the focus that initiate arrhythmia only, they use another catheter, irrigation catheter, that uses cold saline to irrigate the adjacent tissues around the focus that we need to ablate it. This will limit the distraction to the focus that initiates arrhythmia. What is important for us here, we have to be aware that during lengthy ablation procedures, like atrial fibrillation and some difficult cases of ventricular arrhythmias, in these cases, the cardiologist may use too much irrigation fluids, and this may cause volume overload, and patient may not tolerate this volume used for irrigation, especially if he has impaired left myocardial function, and patient may go into pulmonary congestion and pulmonary edema. So we have to be aware, and we have to calculate how much fluids used for irrigation during radiofrequency ablation. and we may need to give diuretics, and we may need, in some cases, to transfer the patient to the ICU, intubated, ventilated, and keep the patient until the lung is dry, will become dry, and then we can extubate these patients. The second mechanism of technique for ablation is the cryoballoon ablation. Contrary to radiofrequency ablation that uses thermal energy, the cryoballoon, it will use the opposite. It will create freezing of the myocardial tissue. Knowing that if we will freeze the myocardial tissue to minus 75 degrees, this will cause permanent damage of the area that was freezed. The cryoballoon ablation uses a catheter, balloon catheter, which the balloon will be filled with nitrous oxide liquid. And this nitrous oxide liquid will be converted to gas. And conversion of liquid to gas will need too much heat. And this heat will be absorbed from the surrounding tissue, causing cooling and the freezing of the surrounding tissue. One important and interesting thing here is that if we will cool the area that we need to ablate it, if we will cool it to, down to minus 4 degrees only, this will produce temporary and reversible damage of this area. So we can use cooling down to minus 4 as a therapeutic test. If we will cool the area that we want to ablate to minus 4, and then we will stimulate the heart to produce arrhythmia, and then we will find that no more arrhythmia will be initiated by stimulation, either electrically or by medications, we know that we are in the correct site, and we will proceed to further cooling to decrease the temperature down to 75 degrees. Also, decreasing the temperature to minus 4 and checking the rhythm and the conduction of the heart, because one of the complications of the ablation technique is heart block. If we will ablate by mistake an area in the conducting system, this will produce heart block. So in this technique, cryoballoon ablation, if we will decrease the temperature to minus 4, and we will find that there is no heart block, so we are away from the conducting busway, and further cooling to minus 75 degrees will not produce the complication of heart block after ablation therapy. Usually in atrial fibrillation, we ablate the circumference around the opening of each pulmonary vein inside the left atrium. So by cryoablation, we have to ablate the whole circumference around the 4 pulmonary veins opening in the left atrium, spot by spot, spot by spot. This will take too much time. But in the cryoballoon, we will inflate the balloon inside the pulmonary veins, and we will cool this balloon. This will cause simultaneous ablation of the whole circumference of the opening of the pulmonary vein inside the left atrium, and this will save too much time. The cryoballoon ablation compared to the radiofrequency ablation is relatively new. So we will find that most of the cases of ablation will uses the radiofrequency ablation. Another technique which uses laser energy to ablate the area of arrhythmia. This is a new emerging technique, and there is a promising results from the use of laser to ablate the arrhythmia. Now, where we will ablate the arrhythmia? Where will locate the ablation catheter? Ablation catheter can be in the right side of the heart, either the right atrium, to ablate most of the arrhythmias like atrial flutter, AV nodular entrant tachycardia, and AV reentry tachycardia. So all these arrhythmias will be ablated in the right atrium. If there is ventricular tachycardia that its origin is from the right ventricle, so ablation will be in the right ventricle. But the most commonly left atrial ablation is ablation for the atrial fibrillation, which is one of the most common types of arrhythmia. Left ventricular ablation, it is for ablation of ventricular tachycardia that originate from the left ventricle. So how we will proceed to the left atrium? We know that it is easy to proceed to the right atrium by through the insertion of the ablation catheter into the femoral vein, advancing it to the inferior vena cava, and then it will go inside the right atrium. And here we can ablate the right atrium or go down with the flow of blood into the right ventricle. But how we can ablate the left atrium? We can ablate the left atrium by piercing the interatrial septum in the area of foramen valve to advance the ablation catheter from the right atrium to the left atrium. And this is the most critical step in the ablation technique, because if by mistake we will pierce any other wall, the lateral wall, the anterior wall, the posterior wall of the right atrium, it will lead to cardiac perforation and bleeding and cardiac tamponade. And this complication is a life-threatening intra-procedural complication that has to be detected as soon as possible, and it has to be treated aggressively immediately. Otherwise, we will lose the patient. So the advancement and piercing of the interatrial septum has to be guided. How we will guide this? We will guide this catheter ablation, catheter piercing the interatrial septum either by the fluoroscopy, but the fluoroscopy is not accurate because it will give us two-dimensional image. So there are more accurate tools to guide the catheter to pass through the interatrial septum from the right to the left atrium. We may use the transesophageal echo, and the transesophageal echo is used usually in most of the cases before starting the AB study and before doing the ablation to rule out the presence of any thrombus in the cardiac chambers. And it will be left inside the esophagus until the catheter will be guided using the transesophageal echo. It will guide the passage of the catheter from the right atrium to the left atrium. A more advanced and more advantageous is the intracardiac echo. This is the intracardiac echo probe. It will be introduced through the femoral sheath to the inferior vena cava and to the right side of the heart. And the intracardiac echo monitoring will guide the passage of the catheter from the right atrium to the left atrium. And the use of intracardiac echo is more accurate in guiding the catheter, ablation catheter, and it avoids a lot of complications that happens from piercing any other wall other than the interatrial septum. Another advantage of the intracardiac echo that it will be operated by the cardiologist who is doing the procedure. It doesn't need extra staff to monitor and to do the transesophageal echo. Also, it can be used as a monitor during the procedure to evaluate the cardiac function. Also, it will detect any air if by mistake air will be entrapped through the catheter and go to the left side of the heart. It can detect any thrombus formation, and also it will detect the bleeding into the pericardium or into the mediastinum early once it happens. So it will protect the patient. Using of intracardiac echo will add to the safety of this procedure, as we will see later on. One of the important steps before doing the ablation is the cardiac mapping. Cardiac mapping, by cardiac mapping, we mean that the cardiologist will do electrophysiological study of the heart. He will study the initiation of electrical impulse, the propagation of electrical impulse, the velocity of conduction, the site of the initiation of the arrhythmia, and through this cardiac mapping, he can initiate the arrhythmia by pacing, by stimulating different areas in the heart to initiate the arrhythmia, to know from where this arrhythmia originates. How this cardiac mapping is done? Cardiac mapping is done by intracardiac ECG. The intracardiac ECG, it uses multi-electrode catheter. 4 electrodes will be inserted into the heart. One will be located high in the right atrium. The second one will be located in the coronary sinus. The third one will be located in the bundle of His, and the fourth one will be located in the right ventricle. So through these 4 electrodes, the cardiologist can detect the intracardiac electrical activity. This is intracardiac ECG. This is the wave produced by the high right atrial electrode. This is by the right ventricle. This is by the bundle of His electrode. This is by the coronary sinus. And this is by the surface ECG, the normal ECG that we are doing. And by these electrodes, he can stimulate different areas of the heart. He can know the initiation site that initiates arrhythmias, and also he can test the success of therapy. So after doing the ablation, he will stimulate, he will pace the area that was the reason for initiation of arrhythmia. If he will fail to initiate arrhythmia after ablation, this means that the technique is successful. More advanced technology is what is called electroanatomic mapping, because electrical mapping only will give us the area of the arrhythmia, the focus that initiate arrhythmia on the image of the fluoroscopy. And this image is only 2D dimension. It is not 3D dimension. If we need to know the exact location of the focus of arrhythmia, we need a 3D dimension. To do this, they are using different kinds of electrodes that will do electroanatomic mapping. 3 electrodes by specific advanced technology. 3 electrodes will be located on the anterior chest wall. Another 3 electrodes will be located in the posterior chest wall, in addition to the 4 electrodes inside the heart. And this will produce 3D image of the cardiac chambers. These are the 3D image. This is one of the pulmonary vein. This is another pulmonary vein, third one, fourth pulmonary vein. And these red spots, it is the areas that was radio frequency ablated. So it will give us a 3D image. And in atrial fibrillation, as we said, we have to ablate the whole circumference around the pulmonary veins. So there must not be any gap between the spots that are ablated in this circumference around the pulmonary veins, because any gap will allow the arrhythmia to recur. So it will add to the precise location of the ablation areas, and this 3D image will add to the success of the ablation technique and decreases the possibility of complications, because by the 3D we will identify the adjacent organs like esophagus. So we will avoid ablation nearby the esophagus, because this may cause esophageal injury. In more advanced techniques, we may, or they may integrate the scans of the CT or the MRI done a few days before the ablation technique. They will integrate these scans to the electroanatomic mapping, and this will increase the accuracy of the electroanatomic mapping. So the electrophysiology lab is a very high technology lab. It uses a high technology tools to add to the safety and success of the procedures. As we know, nothing without no procedure without risks. There are some risks associated with the ablation. Risks due to the vascular access, femoral vein or femoral artery, carry the risk of bleeding, DVT, injury to the artery, ischemia to the limb, as all these complications occur in any catheterization of the heart. Fortunately, these are rare and they can be managed safely and easy to be detected and treated. But there are more serious complications, and it is specific for the ablation techniques, and especially for the complex ablation techniques like the atrial fibrillation and the ventricular tachycardia ablation. And if we will ablate the epicardium of the heart, not the endocardium of the heart, these techniques are highly complicated and carries more risk. The life-threatening intra-procedure complication is bleeding and perforation of the heart and cardiac tamponade, because this has to be detected as soon as possible and has to be aggressively treated. And injury to the adjacent organs like esophagus or phrenic nerve is another complication for ablation. Stroke, peri-procedural stroke, pulmonary venous stenosis, these are the most dangerous complications specific to the ablation technique, and we will talk about it later on. Regarding the bleeding, as we said, if the ablation catheter will perforate any other wall other than the interatrial septum, it will lead to cardiac perforation, bleeding, cardiac tamponade, or bleeding into the mediastinum, and this will cause rapid hemodynamic instability. So if you are monitoring the patient who is doing ablation, and you will detect that there is unexplained rapid hemodynamic disturbance, you cannot explain this with the level of anesthesia of drugs given to the patient. So you have to suspect that this patient might develop cardiac tamponade. You have to inform the cardiologist and to start resuscitation with flows and vasopressors, and the cardiologists have to confirm or rule out the presence of tamponade by echo study. If there is echo, intracardiac echo in place, it will detect the cardiac tamponade. If there is transesophageal echo in place, it will detect the cardiac tamponade. But if he is not using either of these techniques, he has to do transthoracic echo and diagnose the presence of cardiac tamponade, and he has to insert a drainage catheter into the pericardium to drain this tamponade. If the patient was anticoagulated and bleeding continues, you have to reverse the anticoagulation given to the patient to stop the bleeding. This is a very dangerous complication, and it needs immediate detection and immediate management. Otherwise, patient will be lost. This study that was published in 2020, they studied retrogradely more than 100,000 cases who did atrial fibrillation over 4 years, and they recorded an incidence of cardiac perforation of 0.6%. And they found that the risk factors for cardiac perforations are females more than males, morbidly obese patients, and if the intracardiac echo was not used to guide the passage of the ablation catheter from the right side to the left side. And interestingly, they found that the incidence of cardiac perforation during the beginning of the study in year 2013-14 was higher than towards the end of the study years in year 2016 and 17, meaning that the technique is being more familiar and experience is built up more and technology advance. All these will help in reduction of the incidence of cardiac perforation due to ablation technique. Esophageal injury is another serious complication, but this complication will be presented post-procedure by days or weeks. Mostly it starts to be presented after 1 week to several weeks after the ablation technique. The mechanism of esophageal injury is that we are ablating a tissue of the heart which is nearby the esophagus. We know the posterior wall of the left atrium is adjacent to the esophagus. So if we are ablating a tissue of the heart which is nearby the esophagus, or if we will do excessive ablation in this area, this will cause damage of the wall between the esophagus and the atrium. And by day 6 or 7, or after 1 or 2 weeks, this damaged area will be sloughing, and there will be fistula between the left atrium and the esophagus. And this fistula will be presented by sepsis, fever, chest pain, stroke, either air embolism or thromboembolic embolization. If the patient will come with this presentation, and we have a history that he did ablation for atrial fibrillation in the previous weeks, we have to suspect the presence of atrioesophageal fistula. The diagnosis is by contrast-enhanced spiral CT. We will inject contrast intravenously, and we will find that this contrast is visualized inside the esophagus, meaning that there is a fistula between the left atrium and esophagus, and the treatment is surgical. The incidence of this esophageal injury is very rare. It ranges from 0.01 to 0.2%. And treatment is surgical, immediate surgical repair, because the mortality from the atrioesophageal fistula, if treatment is delayed, will be very high. How can we help in preventing esophageal injury? We know that we are monitoring the temperature, esophageal temperature, in most of the cases that receives general anesthesia. So if we will insert the luminal esophageal temperature probe under fluoroscopy into the esophagus and advances it to be behind the left atrium, so if the ablation catheter is nearby the esophagus, there will be a sudden and rapid increase in the temperature recorded by the esophageal temperature probe. And this is warning sign that the cardiologist is nearby the esophagus, and the esophagus here is at increased risk of injury. So we have to inform the cardiologist to stop ablation at this area. A lot of studies show that the esophageal temperature monitoring can decrease the risk of esophageal injury. But on the other hand, some studies found that it is not a reliable technique, because sometimes esophageal injury occurs without any increase in the temperature recorded by the esophageal temperature. So usually we will discuss this option if the cardiologist will do radiofrequency ablation of atrial fibrillation. We will discuss with him if he needs to monitor the esophageal temperature as a warning sign to guard against esophageal injury or not. If he wants, we will advance the esophageal temperature probe under the fluoroscopy to be behind the left atrium and nearby the ablation catheter. Another complication, but this complication occurs more during cryo balloon ablation, because the phrenic nerve is behind the posterior pulmonary veins. So ablation in the pulmonary vein can injure the phrenic nerve. And to prevent phrenic nerve injury during cryoballoon ablation, the cardiologist may advance a probe or electrode into the superior vena cava, and he will stimulate the phrenic nerve, and he will check the response of the phrenic nerve stimulation, which are diaphragmatic contraction. These diaphragmatic contractions can be visualized through the fluoroscopy screen, or it can be palpated manually by the hand. What we will do to allow phrenic nerve stimulation, we have to omit any muscle relaxant medication during general anesthesia if the cardiologist will use phrenic nerve stimulation and monitoring of diaphragmatic muscles. Because if we will give muscle relaxant, there will be no response of the diaphragm to the phrenic nerve stimulation. And now we don't know if the absence of response is due to the muscle relaxant or due to injury of the phrenic nerve. So in these cases, we don't have to use phrenic nerve. We don't have to use any muscle relaxant in the anesthetic management. Air embolism, because catheters will be advanced in case of left atrial fibrillation ablation. Catheter is in the left side of the heart. With any catheterization on the left side, if any air bubbles will be trapped into the ablation catheter, this will produce air embolism. And the management of air embolism is supportive. We will support the circulation with fluids, with vasopressors, with inotropes. We will support the ventilation, and we will give 100% oxygen. We'll put the patient in Trendle impaired position to manage the air embolism. Usually it is mild and not severe. The incidence of stroke, peri-procedural stroke associated with the procedure of ablation is around 0.5%. And stroke can occur either inside the procedure or during the first few days after the ablation procedure. And stroke may be minimal, presented by disturbed level of consciousness, transient disturbance level of consciousness, or some dizziness, or may be transient ischemic attack, or may be severe. And in these studies, they compared the peri-procedure stroke during atrial fibrillation ablations and during cardioversion of the AF. They studied more than 24,000 cases, and they found that the incidence of peri-procedural stroke in ablation therapy is around 0.5%, and the incidence of peri-procedural stroke in the cardioversion is around 0.3%. This is the immediate stroke that can occur during the procedure or immediately after the procedure. But the long-term incidence of stroke is much less if ablation was used to treat atrial fibrillation compared to the cardioversion. Fluid overload and pulmonary edema, we said that during the ablation, radiofrequency ablation, the cardiologist will irrigate the tissues around the ablation catheter with cold saline. And if he uses too much irrigation fluid, this may form overload and may produce pulmonary edema. So we have to be aware of this complication and we have to calculate how much fluid received during the ablation technique. If we need to give diuretics, we will give. If there is pulmonary edema, we can send the patient intubated, ventilated to the ICU until the lung will become clear, and then we will extubate the patient in the ICU. Pulmonary venous stenosis, it is more common in cryoballoon ablation because the opening of the pulmonary veins into the left atrium will be ablated, and it will be complicated with fibrous tissue, and this fibrous tissue will cause stenosis of this opening of the pulmonary veins into the left atrium. Pulmonary vein stenosis will be presented late, weeks to months after the ablation, and it will be presented with pulmonary congestion, chest infection, pulmonary hypertension, hemoptysis. So we have to be aware of this complication if the patient comes few months after ablation therapy with these complications. Now, I think I finished the first part, and if there is any question or comment, we can talk and speak together before we will proceed to the second part of the presentation. Is there any question or comment?
Yes, yes, Dr. Mohamed, thank you for this highly informative lecture. الحقيقة أنا مستفيدة جدا جدا من المحاضرة. دكتور محمد سالم، بعد إذن حضرتك أنا ليا سؤال هقوله لدكتور محمد قبل ما حضرتك تشوف الفلور سأل إيه. هل دكتور محمد إحنا وصلنا ممكن نوصل للمرحلة ان انا يبقى في عندي عيان بري اوبراتيفلي اروح اقول له لا روح اعمل ابليشن الاول لان انت عندك سيفير سايد افكت زي ما حضرتك قلت، او ان في هيمودايناميك انستابيليتي بسبب الاريزميا، فانت حضرتك ممكن تبعته يعمل ابليشن بري اوبراتيفلي، ولا احنا لسه ما احنا لسه في كبري اوبراتيف فيزيشن؟ يعني هل احنا وصلنا للمرحله دي ان احنا نبعته احنا؟
We will send him for the electrophysiologist, cardiologist, and he will decide the proper treatment for this patient. He may, this patient may need more antiarrhythmic drugs, may need to change from one antiarrhythmic to the other, may need to adjust the doses of the antiarrhythmic drugs, or he may need to do ablation. So the one who will decide if the patient is in need for ablation or not is the electrophysiologist cardiologist. And then after stabilization, either through the ablation or through optimization of the medications, we can proceed with the elective surgery.
Okay. My second question, please, Dr. Mohamed. If
Yes.
there is certain arrhythmias that have the more indication for ablation?
Yes, it is well known that certain types of arrhythmia that respond well to ablation, like Wolff-Parkinson-White syndrome and some types of supraventricular tachycardia, these types of arrhythmia respond more to the ablation therapy. So they may start with ablation therapy for these kinds of arrhythmias.
اكيد حضرتك هتقول لنا في الجزء الثاني الانستاتيك بروسيدور، صح ولا انا غلطانه؟
تمام، يس اكيد.
خلاص يبقى انا مش هسال. اتفضل حضرتك يا دكتور محمد سالم، اتفضل. Any question from the floor?
السلام عليكم.
عليكم السلام ورحمه الله وبركاته. وسام،
ازي حضرتك يا فندم؟
ازيك؟
محمد، ازي حضرتك؟
اهلا وسهلا دكتور وسام. اهلا وسهلا.
الله يخليك يا فندم. I have one question regarding the prolonged QT interval. What is the precautions should be taken in consideration during induction of anesthesia or anesthesia for elective surgery?
QT interval, prolonged QT intervals may be due to electrolyte disturbance, maybe due to certain drugs. So we have to refer the patient to the cardiologist, and he can assess the patient, and he can control the reversible causes of prolonged QT interval in these patients. After getting optimization of the patient, after correction of the reversible causes for QT interval, we can proceed for the elective surgery after correction of the reason that causes prolonged QT interval.
Okay, so this is for elective surgery. For emergent surgery or urgent surgery, is there any precautions should be taken during the procedure?
I think, but I'm not sure, that if we can correct any electrolyte disturbance in this situation, if we are able to correct any electrolyte disturbance for these cases, hypomagnesemia, any electrolyte disturbance has to be corrected as fast as we can before proceeding to the or going side by side with the procedure in emergency situation.
بعد إذن حضرتك دكتور محمد, I can add in any type of arrhythmias that cause hemodynamic instability should be corrected firstly, even before the emergency surgery. And if it has no effect on the hemodynamic, you can proceed by cautions.
Yes, yes, of course, yes.
The main issue here is the hemodynamic stability.
Yes, yeah.
Thank you, Dr. Mohamed. Thank you, Dr. Safa.
You.
And regards to Dr. Salim, the moderator. Thank you.
Salim.
اهلا بك دكتور وسام، شكرا جزيلا.
اهلا بحضرتك دكتور سالم، ازي حضرتك؟
Any question from the floor? دكتور ياسر توب. دكتور ياسر توب. دكتور سمير الكفراوي. Always sharing us by a very informative question.
Thank you, Dr. Safa. I don't have any question because I really am enjoyed the lecture's presentation, and it's outside my area of practice, but I enjoyed it. Thank you.
Okay. Dr. سمير الكفراوي. Okay.
So can we proceed, Safa?
To the second part.
Okay.
Second. Okay.
Now we are in the electrophysiology lab. It is the site, it is one of the off-sites that we have to give anesthesia and sedation in. As we see, this is the image of the electrophysiology lab. Very crowded, limited space, too much machines, fluoroscopy machine, echo machine, large monitors in front of the cardiologist, and large back table for the scrub nurses, infusion pump, and we cannot find the patients between inside this EP lab from the overcrowding of machines and tables inside the lab. So anesthesia in the offsite carries high risk and more challenging to the anesthesiologist, to the degree that ASA published in 1994 its statement on anesthesia outside the OR. This statement was reaffirmed lastly in 2018. And they put 10 conditions for any off-site location, any out of OR location to be fulfilled before we can give anesthesia or sedation in this location. The first one, we have to have primary source of oxygen and backup source of oxygen. If we have central oxygen, we have to have another backup source of oxygen in case of the failure of the primary source of oxygen. We have to have an adequate and reliable source of suction. We have to have adequate and reliable scavenging system in the off-site location if we will use inhalational anesthetics. Ambu bag, adequate anesthetic drugs, and adequate monitoring system exactly like the OR. Sufficient electrical outlet and UPS outlets. UPS is uninterrupted power supply outlets. These outlets will be connected to the generators. So if the main electrical source will fail, this outlet still connected to the generator, and we have to connect our monitor and anesthesia machine to the UPS outlet and suction machine to the UPS outlet. Also, we have to have adequate illumination inside the off-site location. We have to have crash trolley and defibrillator inside or nearby the off-site location. And we have to have adequately trained staff, either nurses or technicians, to assist and help the anesthesiologists, especially in emergency situations. We have to have all applicable building safety codes like emergency exits and like fire safety tools inside the out of OR location, exactly like the OR. And there must be a post-anesthesia care area to care the patients after the anesthesia. And this backhoe unit has to be monitored, has to be equipped with monitors and emergency tools to rescue the patient if he will suffer any emergency situation in the recovery room. The offsite location is away from the OR. Usually the tools and the facilities inside this offsite location are deficient compared to the OR. The space is inadequate, as we said, and there is no immediate help. So if any life-threatening emergency will happen in the offsite location, until you get the help into the out of OR location, there will be some time. So you have to put this into consideration. Airway is more challenging. We consider any airway management outside the OR carries more difficulty compared to airway management inside the OR. The procedure table itself is challenging because it has no chance to change the position. We cannot put the procedure table in the semi-sitting or ramping position in case of obese patients or difficult intubation cases. The only position that the patient would be lying flat, supine in this on this table. Also, we have difficulty to access the patient during the procedures because there is limited space and too much machines and towers. The position of the arm is usually tucked besides the patient. So if we will need during emergency situation inside the procedure, we will need to insert more lines to give inotropes or to give fluids or to give blood to the patient. We will take time to secure the line in the tucked arms beside the patient. So also the setup of the electrophysiology room, there will be fluoroscopy machine, echo machine, either transesophageal or thoracic echo machine, large back table for the scrub nurse. Sometimes there is an MRI system inside the electrophysiology room or CT system. Sometimes there is a defibrillator is always there, and crash trolley is always there inside the room. There is large monitor screen for the electrophysiologist, cardiologist. There is radio contrast infusion system, and the fluoroscopy imaging equipment. It rotates around the patient to give AB views, lateral views, PA views. So the rotation of the fluoroscopy machine may dislodge or disconnect the breathing circuit, may disconnect the IV extensions, or cause a disconnection of the monitoring cables. So the situation in emergency, if there is any life-threatening emergency situation inside the electrophysiology room, the situation and management will be very difficult. And it is advisable to make conservative management decisions from the beginning. So we have to secure more venous access. We have to use all tools to monitor the patient, all the available tools. If we are suspecting that this patient may need intubation during the procedure, it is better to secure the airway from the beginning, and don't wait until the emergency situation happens and then to start to secure the airway and insert lines and monitor the blood pressure directly through arterial cannula. Do this from the start in high complex ablation techniques in order to save time and save the life of the patients. This study was published in 2009, and they examined the ASA closed claims database, and they found that significant claims against anesthesiologists come from giving anesthesia or sedation outside the OR. The high order of claims, the highest one, it came from the endoscopy room. The second in order came from the cath lab and the electrophysiology room. And when they judged these claims, they found that most of these complications can be prevented by using better monitoring. So we have to get monitors in the off-site locations similar to that monitors which is present inside the OR. How to assess these patients pre-operatively? As all the patients who will receive sedation or arrhythmia, we have to assess the airway, and we have to consider that there is difficulty in dealing with the airway inside the out of OR locations. There is usually these locations are deficient of a lot of tools that we can use during difficult airway management. So we have to be very cautious in assessment of the airway of the patients pre-operatively. We have to assess the cardiopulmonary status of the patient, because patient may have congestive heart failure, may have valvular heart disease, may have impaired ventricular function, and these conditions will increase the risk associated with the anesthesia if it will be given to these patients. If there is a chance to optimize this patient before giving anesthesia or sedation, we have to send back the patient to the cardiologist to optimize this patient before sending him to the EP lab. Other comorbidities that increases the risk includes COPD, obstructive sleep apnea, morbid obesity. So we have to be aware of this, and if there is any optimization can be done for these patients, we have to wait until these morbidities are optimized. Medications, most of these patients are maintained on antiarrhythmic and anticoagulant medications, and other medications that can optimize the cardiac status that led to the arrhythmia, like antihypertensive medications, anti-failure medications, or anti-ischemia medications, and the adjustment and optimization of these medication will be the job of the cardiologist. History of allergy, because we may use contrast injection during the technique. And the kidney function also is important, because if the patient will receive contrast, this may be injurious to the impaired kidney of the patient. Before the procedure, we have to be ready. We have to check the anesthesia machine, ensure and confirm that it is functioning well. There is well and strong suction. There is backup oxygen, and all the conditions mentioned in the ASA statement. We have to check its availability before we proceed for anesthesia in any off-site location. Also, we have to have tools to deal with difficult airways, because, as we said, management of the airway is more difficult in out of OR locations. All the anesthesia drugs that we will use must be available. And we have to prepare the emergency medications, because, as we said, in life-threatening complications like cardiac tamponade, there is no time to start preparing the inotropes and vasopressors. So we have to prepare it and keep it ready before we start the procedure, because time here means life of the patient. As we are walking away from the OR, so nobody will come to help us immediately. So we have to arrange with our colleagues. If we will need help, we will call whom, and to inform the one that we will call him if any emergency situation will arise and we need his help. So we will arrange and give him an idea about the procedure and about the management before we start. And we have to remember the statement that it is advisable to make conservative management decisions before starting the ablation procedure. Monitoring, as any patient will receive general anesthesia or even sedation, we have standard monitors. We will not give sedation or anesthesia without the availability of ECG, non-invasive blood pressure, pulse oximetry, and end-tidal CO2. Invasive monitoring is preferred in high complex ablation procedures like atrial fibrillation, unstable VTAC, or epicardial ablation. And these invasive arterial and central lines can be used to aspirate blood samples for frequent ACT monitoring during the technique to monitor the anticoagulation given to the patient. Temperature monitoring, we said that in some ablation techniques, we may use the luminal esophageal temperature probe to monitor the rise of the esophageal temperature, and this is a warning sign that the ablation is nearby the esophagus. So we have to stop ablation here in order to decrease the incidence of esophageal injury. Urinary catheter in lengthy procedures, and those procedures that we will use irrigation fluid to cool the adjacent area of the myocardium and to keep the injury to the focus of arrhythmia only, and so to save the adjacent myocardial tissue from injury. So in these situations, we have to insert urinary catheter. As we said before, transesophageal echo and intracardiac echo, if it is in place, can be used to monitor the ventricular function, the presence of any complication like air embolism or bleeding into the pericardium. It will detect these complications early, and it will help in saving the life of the patient. For the anesthetic considerations, the ideal anesthetic strategy for this patient is to keep the patient calm, motionless, and we will know why motionless, and his ventilation and respiration is smooth. There is no any kind of airway obstruction. There is no vigorous movement of the respiration and chest wall. And the anesthesia or sedation medications must not interfere with the arrhythmia induction. Unfortunately, most of our sedative and anesthetic drugs may interfere with the initiation of arrhythmia or propagation of arrhythmia. So we will use the least medications that interfere with the electrophysiological study. Certain types of arrhythmia like SVT and certain types of VTAC may be very sensitive to any medications, sedative medications or anesthetic medications. And if the patient will receive any type of sedation, even light sedation, this will make the induction of this arrhythmia during the electrophysiological study is very difficult. So in these cases, we may avoid even sedation, just assure the patient and don't give any sedative medications except if strongly indicated. For certain types of ablation techniques, like in EF and in scar-related VTAC, the technique is time consuming and it is complex technique. So patient may not tolerate to be sedated for a long time, lying down, motionless. He will not move for a long time under sedation. So in these cases, we may prefer, especially for our kinds of patients, we may prefer the general anesthesia over the conscious sedation. Also for epicardial access for ablation, general anesthesia is preferred. If the patient is uncooperative, very anxious, or he was a child, so general anesthesia is more preferred than conscious sedation. Also, the use of intra-procedural transesophageal echo to monitor and guide the passage of the catheter from the right side of the heart to the left side. So the probe of the transesophageal echo will be kept inside the esophagus for a long time, because before the start of ablation, transesophageal echo will be used to rule out the presence of any arrhythmia. And during the procedure, it will monitor the passage of the catheter until the catheter will perforate the interarterial septum and go into the left atrium. So it will remain inside the throat of the patient for more than 1 or 1.5 hours or even 2 hours until we reach to this step. So this will be difficult to be tolerated by the patient under sedation. And in these cases, the general anesthesia may be more appropriate. When we compare general anesthesia versus conscious sedation, there are certain parameters that we have to use to compare which is more better. These parameters involve patient satisfaction, recurrence of arrhythmias in the first year after ablation, reduction in the time of the procedure, incidence of intra-procedural complications, and fluoroscopy times. Using these parameters, a lot of studies found that in complex ablation techniques, like during atrial fibrillation, general anesthesia is favorable compared to conscious sedation, because patient will be more satisfied. The incidence of recurrence of arrhythmia in the first year after ablation is less when general anesthesia is used, and the time of the procedure is less with general anesthesia, and complications are less, and the use of fluoroscopy time is less. A lot of studies like this one that was published in 2011 in the Heart Rhythm Journal, they found that general anesthesia is favorable if we compare it to conscious sedation according to all these parameters. Some other studies found that conscious sedation is comparable to general anesthesia, but one point, which is the incidence of recurrence of atrial fibrillation in the first year after ablation, there is nearly an agreement between most of the studies that it is less, the incidence of recurrence is less if general anesthesia was used, because the patient is motionless during general anesthesia. The ventilation is smooth, and we can control the ventilation in relation to general anesthesia compared to conscious sedation. So the benefits of conscious sedation during ablation technique, it will cause less hemodynamic instability compared to general anesthesia. It is more economic. The results may not be inferior to general anesthesia according to some studies. We may not require anesthetists to give conscious sedation in some situations, because we have if we have a cardiologist who is doing the procedure and privileged to give sedation, and a nurse who is privileged to give sedation, both of them, they can give conscious sedation to the patient, and they may not need anesthesiologists, because sometimes there is a shortage for anesthesia personnel to cover all the outside areas. During conscious sedation, it is easier to induce arrhythmia. Pain can be used as a warning sign. So if the patient receives general anesthesia, he will not feel that pain, and pain may be a warning sign and prevent against the occurrence of some complications. The advantage of general anesthesia is that we have secured airway. Ventilation is controlled, so there is no hypercapnia, no hypoventilation, no obstruction of the airway. And the patient is more satisfied, and the cardiologist who is doing the procedure is more satisfied if the patient is under general anesthesia. And if any life-threatening emergency happened, we can concentrate on hemodynamic stabilization, because already the airway is secured and ventilation is secured. So we can do all our effort to stabilize the patient hemodynamically only. We will not be busy in securing the airway and ventilation in this situation. The decision will depend on the preference of the patient, the complexity of the procedure, the expected duration of the procedure, what is the preference of the cardiologist, because as we said, in certain types of arrhythmias, any anesthesia drugs may depress and these arrhythmias and make it difficult to induce, and the associated comorbidities in the patient. So the decision depends on a lot of factors. No certain anesthetic technique is suitable for all the patients. We have to tailor the technique of anesthesia according to the situation. Next, who will give anesthesia for ablation in the electrophysiology lab? Is it better to allow the cardiac anesthetist or the general anesthetist to give anesthesia for these techniques? There is a debate between cardiac anesthesiologists and general anesthetists that who will give anesthesia for these cases. Cardiac anesthesiologists believe that they are more familiar with arrhythmias and antiarrhythmic drugs and inotropes, vasopressors, and left ventricular assist device. And if the patient will need cardiac surgery, if there is bleeding that was not controlled with the drainage catheter, so patient will be shifted to the cardiac OR for open surgery to control the bleeding. The presence of cardiac anesthesiologist will guarantee the continuity of care. He will manage the patient from the AAP lab to the cardiac OR. The other opinion, which adopt the opinion that general anesthetist is better to give anesthesia for these cases, they depend on that familiarity with arrhythmias, antiarrhythmic drugs, and inotropes and vasopressors and all techniques that support the circulation and hemodynamics is basic knowledge for any anesthesiologist. It doesn't need the cardiac anesthesia to do these tasks. And also, the cardiac anesthesiologist is not used to work outside the cardiac OR, and he is not used to give conscious sedation to the patients. He is used to give anesthesia based on high dose of opioids and muscle relaxant. And both are not used in the electrophysiology. We do not use high dose opioids because it will suppress the sympathetic system and it will prevent the induction of arrhythmias. And also in some cases, we don't give any muscle relaxant if the electrophysiology will use phrenic nerve stimulation to monitor the diaphragmatic contraction. So the strategy is different in cardiac OR than in anesthesia in the electrophysiology procedure. In this journal, cardiothoracic vascular anesthesia, in 2011, there was a debate between who is better to give anesthesia for these techniques. And our colleague, Dr. Nabil Al-Kasabani, who is working as a professor of anesthesia in University of Virginia, and we are proud that he is one of the graduates of Alexandria Hospital. He was the one who adopted and wrote the opinion that general anesthetist is the one who has to give anesthesia for these techniques. The effect of medications on the electrophysiology lab, we will get different results of research, which is the proper medication to be used during the electrophysiology study and ablation techniques. Regarding sedation with ketamine, there is no contraindication. There is no proof that ketamine can inhibit any arrhythmia. So according to most of the studies, can be used in the AP to sedate the patient. And sevoflurane is safe to be used. Nitrous oxide, we have limited data about the use of nitrous oxide, but we have to think because ablation techniques, especially those involving the left side of the heart, carry the risk of air embolism, and nitrous oxide will expand any air and will deteriorate the situation if there is air embolism. Propofol can be used for sedation of the patient in the EP lab, but it can suppress certain types of arrhythmias. So if we will use propofol, we have to inform the electrophysiology cardiologist because in certain types of arrhythmia, it will be very difficult to be induced in the presence of sedation with propofol. Intermittent doses or continuous infusion of midazolam and fentanyl can be used for sedation of these patients. Remifentanil can be used in the epicardial V-tach ablation safely. The medication that there is agreement that it must not be used in the electrophysiology lab is the dexmedetomidine, the Brezitex, because it is a strong antiarrhythmic. So we don't have to use it. It is not welcomed in the electrophysiology lab. If there is difficulty to induce arrhythmia, we have to decrease the doses of the sedatives. We have to lighten the level of anesthesia. We have to shift from one drug to another drug. We have to shift from IV total intravenous anesthesia to inhalational anesthesia until we can induce, the cardiologist can induce the arrhythmia to do the electrophysiological study. Regarding ventilation during the ablation technique, the requirement for ablation technique, we have to give a chance for the ablation catheter to come into contact and to be sticky to the left atrial area, which will be ablated in order to increase the success rate of the ablation technique. If the patient is taking deep breaths, either spontaneous, or if the patient is sedated and he is partially obstructed, or if we are ventilating the patient with large tidal volume, all these situations will cause deep and more excursion of the chest wall during the ventilation. And the deep ventilation and the vigorous movement and the excessive tidal volume will lead to displacement of the left atrial wall from the ablation catheter. It will go away from the ablation catheter during the chest wall expansion, and then it will come back during expiration to touch the ablation catheter again. What we need the ablation catheter is in close contact with the area that will be ablated during both inspiration and expiration. To fulfill that, if you will sedate the patient, we have to confirm that the ventilation is smooth, unobstructed, and calm, and patient does not move, does not cough. So in complex situations and in lengthy operations and in cases of atrial fibrillation, I think the general anesthesia will be better choice. How to ventilate this patient? We will ventilate these patients with low tidal volume, 200 to 300 ml. And to prevent atelectasis from this low tidal volume ventilation, we have to increase the PEEP from 5 to 10 centimeter water, and the IE ratio will be prolonged inspiration 1:1. This will cause little chest expansion during ventilation, and we can compensate for the hypercarbia with increasing the frequency. If we will do that, the success rate will be higher if we use this ventilatory strategy. Some centers will use the high frequency jet ventilation during the ablation of the atrial fibrillation, and there are some studies supporting this technique for ventilation, because during high frequency jet ventilation, the chest is nearly motionless. This will add to close contact of the ablation catheter to the area that will be ablated. We will ablate the left side of the heart, either the left atrium or left ventricle. We have to anticoagulate the patient because the presence of the ablation catheter in the left side of the heart may initiate thrombus formation. So the patient has to be anticoagulated. During atrial fibrillation, once the cardiologist will perforate the interatrial septum, we have to give a therapeutic dose of heparin to start anticoagulation, and it will be monitored by the accelerated clotting time. And we have to keep the ACT more than 300 seconds. So it will be between 300 to 400 seconds during the ablation of the atrial fibrillation. If the ablation in the left ventricle, we will give 5 to 10,000 heparin after insertion of the femoral sheath, and we will keep the ACT between 250 to 300 seconds. And we will maintain the ACT at these levels in both AF and in both VTAC ablation until the procedure finishes by either heparin infusion or subsequent boluses of heparin. And then at the end of the procedure, we will monitor the ACT. If it is significantly high, we can partially reverse the effect of heparin with discussion of this issue with the cardiologist, because they need the patient a little bit anticoagulated, and sooner, after a few hours in the postoperative period, they will start anticoagulation to the patient. At the end of the procedure, usually the cardiologist will do transthoracic echo or transesophageal echo to confirm that there is no bleeding either in the pericardium or in the mediastinum. And then we will shift the patient. Usually we will extubate the patient and shift him to the post-anesthesia care unit. And we will monitor the hemodynamics of the patient in the post-anesthesia care unit. Any hemodynamic instability in the post-anesthesia care unit has to raise the idea that patient may be bleeding and there may be cardiac tamponade. And immediately we have to do transthoracic echo to rule out or to prove that the patient has bleeding and cardiac tamponade. And these complications has to be managed rapidly and aggressively to treat the patient. Most of the procedures for ablation, it will be done as a day case procedure, and patient can go home after a few hours after the ablation. But complex ablation techniques like atrial fibrillation ablation and VTAC ablation and epicardial ablation, patient has to be monitored and observed for 24 hours after the procedure to rule out any of the mentioned complications that can occur immediately after the procedure. The take-home message, as we discovered, that understanding the electrophysiology of the heart, the technique of the ablation are mandatory for the anesthesiologist in order to be successful in managing ablation technique in the EP lab. And the EP lab is an off-site location. It is full of machines and towers and tables, and the access to the patient is difficult. And the facilities for anesthesia and rescue tools for any airway, usually it is not available compared to the OR. So it is a challenging location to give anesthesia or sedation in, especially when we are dealing with a high-risk patient. Cardiac patient has a lot of comorbidities, and doing a high-risk procedure that carry some of their complication, like the cardiac perforation and cardiac tamponade. So we have to prepare to deal with these life-threatening complications from the beginning. Also, the anesthetic plan has to be tailored according to the situation, according to the patient, preference of the patient, comorbidities of the patient, according to the type of the patient, anxious or stable, adult or child, and according to the preference of the cardiologist. So there is no certain anesthetic technique suitable for all patients, all procedure done in the electrophysiology lab. And we have to be very conservative from the beginning. We have to expect that we are dealing with critically ill patient with high risk procedure that carries risk for life-threatening complications. So we have to prepare all the facilities to rescue these patients from these life-threatening complications. Thank you. Sorry for this very long presentation.
Thank you very much, Dr. Mohamed, for this very nice presentation. It's you get us a very good journey in the world. Not prepared to manage such critical cardiac situation outside operating room. The cath lab suite is very crowded place with many advanced instrumentation, very narrow place. And usually when you proceed in this place, we should be very prepared and anticipating all the complication and the maneuvers that you're going to do in this situation. I guess the cardiac anesthetist is the one able to manage such situation outside cardiac surgery suite. I would like to ask you one question, please. What about the recurrent cases and how much the recurrence after ablation and how to manage recurrent case? Second question is the patient usually comes in ablation techniques with ICD. How to manage anesthesia with such devices in ablation technique. Also, sometimes ventricular tachycardia patient, they have poor cardiac function and they have some mechanical assisting device like intra-aortic balloon, like left ventricular device. How we can manage such situation? Is etomidate a preferable anesthetic induction agent than the drugs that you mentioned? Many thanks for you. It's a very big lecture involving all the items of arrhythmia ablation. Many thanks.
You are welcome, Dr. Mohamed. Regarding your opinion, it is very respectable opinion. And as I said, there is a debate between the cardiac anesthesiologist and general anesthesiologist who is better to manage this technique. We cannot depend only on the who is better, but we have to respect the availability also, because in many cases, in many centers, we don't have a lot of cardiac anesthesiologists. So we may allow the general anesthetist to give anesthesia and sedation in the cath lab. Second, if the patient, the ICD is one of the tools that can treat certain types of arrhythmias. So in case of failure of the ICD, or non-availability of the ICD, we can go to the ablation technique. So in cases of VTAC, the order is medications and then ICD and then the ablation technique. If the ICD is not available or it fails to treat to control the VTAC, we will go to the ablation technique. Usually in VTAC, we may not need to give anesthesia. We may give only sedation because certain types of VTAC are very sensitive to the anesthetic drugs, and sometimes they are calling us as anesthesiologists only to give MAC and to monitor the patient and to help in stabilization of the patient, even without giving any kind of sedation, and the procedure is done completely under local anesthesia only. Regarding the question of etomidate, I didn't get any study that compared etomidate to the other drugs. Etomidate, we know that it is a cardiovascular stable drug, and these kind of drugs may not be preferable from my point of view, but I didn't get any study confirming this. The cardiovascular stable medications, usually it suppresses the induction of the initiation and stimulation of the arrhythmia. So from this point of view, it may not be preferred compared to other medications. But this is my opinion, may not be totally correct. Any other question?
Yes, Dr. Mohamed, Dr. Samir asked about during the ablation of atrial fibrillation, would the iatrogenic heart block may occur?
Yeah, It may occur. And heart block during the ablation may be temporary and may be permanent, because injury of the conducting system, it may be only just edema and inflammation resulting from the thermal injury in adjacent focus to the conducting system. And if it is temporary, it will be resolved. If it is permanent, it will need to insert pacemakers. Sometimes the electrophysiologist can insert the pacemaker if the heart block will affect the hemodynamics of the patient. He can insert the pacemaker in the same session, and then he will monitor the dependence of this patient on the pacemaker later on after a certain period. When the inflammation and the edema will resolve, patient may recover from this temporary heart block. But if the patient didn't recover, he will live with the pacemaker for the whole life.
Okay. Dr. Samir, you still raised your hand. Do you want another question? Yes.
دكتورة
We have another
صفاء
question. تفضل.
السلام عليكم.
وعليكم السلام
عليكم
ورحمة الله
السلام
وبركاته.
ورحمة الله وبركاته.
First of all, طبعا thanks to Professor Safa for this valuable and very informative lecture from an expert, and this is differs. Lectures from experts always differ. We all listening for I think now more than 2 hours, enjoying this lecture. We have no experience in this topic. This is my first time to read or listen to this informative one. Actually, I want to thank Professor Mohamed. I am always stuck to Alexandria University. I graduated there in 1989, and so they are very precious for me. And I am following Dr. Nabil also. Thanks, Professor Mohamed. For our colleagues, juniors, who are not used to work in such rooms, because EP lab is somewhat similar to our neurosurgical rooms now. We have too much machines. We have neuronavigations, microscopies, the intraoperative neurophysiological monitoring machine, and this technique has to be influenced and should be trained to our junior staff, because it's as Dr. Mohamed said, it is difficult to connect the patient safely to your machine and to your IV set and infusion pumps and so ever. For our colleagues who are used to do anesthesia in remote areas, I think this lecture is perfect for them.
Yes.
And it's very valuable for us to take the journey from the start of the techniques of ablations itself. This is my first time to listen to a whole lecture on ablation. So thank you, Professor Mohamed. Thank you, Professor Safa. And we welcome new members in our club. I think Dr. Rania with us now. She is Yemeni doctor, Yemeni anesthesia doctor. Now we are starting to go to Asia. Okay, and we are waiting for more lectures from Professor Mohamed about cardiac anesthesia or cardiac patients during our general anesthesia. Thank you and good night.
Welcome.
Thank you.
Welcome,
Thank you.
Maybe the last question someone asked about the duration after ablation that patient can be anesthetized safely for elective surgery, Dr. Mohamed.
It was not mentioned in any literature. We can give anesthesia safely after ablation technique, but we can consult in these cases. We can consult the electrophysiology cardiologist if he has any concern or not for such patient to proceed for any other procedure that needs general anesthesia. I think
Yes.
there is no contraindication, but for safety, we better to consult the electrophysiologist, cardiologist. For my knowledge, I didn't get any knowledge about the safe period.
Yes, allow me, please. I suppose that if the patient have no post-operative hemodynamic instability or bleeding or any post-operative or post-ablation complication, we can proceed with cautions, of course.
Yes,
I
of
suppose
course.
that.
And the question is about the elective surgery. And anyway, we do not do any elective surgery if the patient is hemodynamically unstable for any reason, either ablation, post-ablation, or any other reason. This is not the situation that we will proceed for any elective surgery for these patients.
Of course. Just I have 4 minutes. In these 4 minutes, Wissam, you want to ask any question?
Yes, please, Dr. Safa.
طب يعني خد دقيقة واحدة عشان أنا لازم أختم ختام كويس للدكتور محمد بعد يعني هذه لا يعني بقى اديني فرصة يا وسام اتفضل. هم 4 minutes اللي معانا فاضيين.
Thank you, Professor Dr. Mohamed, for your valuable presentation. My question is about how can we help the cardiologist to induce arrhythmias in case of masking arrhythmia, pharmacologically or what?
Yes, he will induce arrhythmia either by electrical pacing through the intracardiac electrodes that he is used to record the intracardiac electrical activity. And through these electrodes, he can stimulate different areas in the heart to produce arrhythmia. If he fails to produce arrhythmia, we can use either isoprel or epinephrine to induce arrhythmia. We will start with low doses, and then we can increase the doses according to the response. If still the arrhythmia cannot be induced, we have to lighten the level of anesthesia. We have to shift from one drug to another drug. We may need to wake up the patient if the patient is sedated, so we can wake up the patient, keep the patient alert and anxious, because the sympathetic activity can help in inducing the arrhythmia. I think these are the tools that we have to help for induction of arrhythmia during ablation technique.
متشكرة جدا جدا لحضرتك دكتور محمد. يعني الحقيقة يعني ما فيش الحمد لله ما فيش ثانية دماغنا سرحت. حضرتك كنت مسيطر على البرين بتاعنا كويس جدا جدا. واحنا انا شخصيا اول مره في حياتي اسمع محاضره عن الابليشن، والمحاضره كانت رائعه واكثر من رائعه ومفيده جدا جدا. ان شاء الله كلنا نستفيد. وزي ما الدكتور سمير قال ادت امنها للابليشن، لا هي للريموت برضو انستيزيا كير، الناس اللي بيعملوا في الريموت بليسز، فدي حاجه كويسه جدا جدا. بشكر حضرتك جدا لوقتك، بشكر حضرتك للدعم الغير مسبوق من حضرتك، بشكر الاستاذ الدكتور محمد سالم على ادارته للجلسه بمنتهى البراعه. ربنا يكرم حضرتك. بشكر كل الساده الضيوف المحترمين اللي شرفونا النهارده وقعدوا يستمتعوا، وان شاء الله في ميزان حسنات حضرتك يعني كجبل احد ان شاء الله يا دكتور محمد. متشكره جدا جدا لحضرتك ومنتظره منك الكثير والكثير والكثير. شكرا لحضرتك. شكرا لحضرتك، شكرا جزيلا. السلام عليكم ورحمه الله وبركاته. السلام عليكم.
وعليكم السلام ورحمه الله وبركاته.
شكرا جدا دكتور محمد. المحاضره بصراحه يعني
رائعه بصراحه.
الله يخليك يا دكتور صفاء. الحمد لله.
ربنا يحمي حضرتك، ربنا يحمي حضرتك ويكبر خاطرك ان شاء الله.
حضرتك اشتغلت
نعم،
اشتغلت حضرتك ريكارنت كيسز، يعني واحد عمل ابليشن قبل كده وراجع تاني يعمل ابليشن؟
اشتغلت حالات ريكارنت
بنفس ولا كان في ديفرنس او في اي حاجه؟
لا، في نفس ايه حضرتك؟
بنفس التكنيك يعني، ولا حضرتك طبعا بتمانج كل اريزميا بتكنيك معين في التخدير؟ يعني مثلا الاي اف هيبقى لونج فنديله جنرال انستيزيا، مثلا الاس في تي او حاجه زي كده تبقى شورت نديله مثلا سيديشن. هل ديب سيديشن it has a place ولا راي حضرتك فيها؟
it has a place if the patient it has a place after doing the electrophysiological study. after the electrophysiological study, now the cardiologist, now he knows well where is the origin of arrhythmia, how it is propagated, what are the areas that the patient, the ablation will be done on. So after this electrophysiological study, we can give deep sedation. And at the end of the ablation, if the cardiologist wants to test the ablation, if it is successful or not, and he wants to stimulate the arrhythmia again to check if the arrhythmia will recur with stimulation after ablation or not, we can lighten the level of the sedation. So we have to communicate with the cardiologist about his what he will do in order to tailor the sedation technique or the anesthesia according to the situation.
شكرا لحضرتك يا بيه وسعدنا.
الله يخليك، انا اللي اسعد، فرصه سعيده ان انا اتعرفت بحضرتك ان شاء الله
بحضرتك.
نستمع على خير يا رب.
مع السلامه.
السلام عليكم.
عليكم السلام ورحمه الله
السلام عليكم ورحمه الله وبركاته.
عليكم السلام ورحمه الله وبركاته.